So if a patient is having glaucoma, what visual field defects the patient will have? What visual field defects the patient will have? First of all, we need to understand the visual field defects, guys. Okay, I'm not right. Just look over here. Imagine, guys, this is the visual field. Imagine here is this is the visual field. This is the central visual field. So, as the patient is having glaucoma, what will happen is, first a small blind spot appears, yani a small blind spot appears in the paracentral area. Okay? Yani localized loss of vision surrounded by a good vision is called as what? Scotoma. So, first what will happen? The patient will have paracentral scotoma. If the patient is not treated for paracentral, slowly this scotoma goes towards the pericentral area. It becomes pericentral scotoma. Okay? So, first there is paracentral scotoma, then it is pericentral scotoma. Right? Then it takes the shape of an arc, that is called as arcuate scotoma. So, first there is small paracentral scotoma, small dot developing at the center. Then that dot extends and becomes pericentral. Then it becomes what? Arcuate scotoma. This arcuate scotoma takes the shape of a sickle, which is called as Seidel scotoma. Then there is double arcuate scotoma. Right? One more arc total develops and it becomes what? Double arcuate scotoma. Due to all these scotomas occurring, scotoma is what? Localized loss of vision surrounded by a good normal vision. Due to all these scotomas developing, the patient will have generalized constriction of the vision and generalized depression of the vision. Once again, guys, we are discussing about what? We are discussing about the visual field defects that you see in glaucoma. So, the first visual field defect that you see is what? The patient will have paracentral scotoma, then pericentral scotoma, then arcuate scotoma, then Seidel scotoma, then double arcuate scotoma. Then it becomes what? Double arcuate scotoma. And then what will happen to the vision? There is generalized constriction of the vision and there is generalized depression of the vision. So, remember guys, this visual field defects, are they seen just in glaucoma? Visual field defects can be seen in glaucoma as well as some other conditions of the eye such as optic neuritis or any retrobulbar neuritis. Yani ki neuro-ophthalmic conditions, you might see visual field defects. So, regarding the visual field defects, there are 8 visual field defects that you see in glaucoma. The first visual field defect is scotoma. Scotoma occurring at what? What is scotoma? Localized loss of vision surrounded by a good vision is called as scotoma. Where is that scotoma occurring, guys? Paracentral area. So, first there is paracentral scotoma. Paracentral scotoma. Then after paracentral scotoma, what will happen, guys? Then there is pericentral scotoma. This blind spot extends in the shape of arc. Okay? Pericentral scotoma. Then it becomes what? Arcuate scotoma. The third visual field defect that you see is arcuate scotoma. Then after arcuate scotoma, there is double arcuate scotoma and Seidel scotoma. In the form of sickle, it will extend. So, then there is Seidel scotoma. Okay? Seidel scotoma, that becomes double arcuate scotoma. Right? Due to all these scotomas, what will happen to the vision, guys? The patient will have generalized constriction of the vision and generalized depression of the vision. These are the visual field defects that you see in glaucoma. These are the visual field defects that you see in glaucoma, right? So, these are the most important visual field defects that we have discussed, right? First, there is paracentral, then there is germ scotoma, right? Then there is arcuate scotoma, right? Then there is Seidel scotoma, then there is double arcuate scotoma, double arcuate scotoma. Remember which visual field is first to be lost over here? The nasal field is first to be damaged and the temporal, as it is the largest visual field, it is last to be damaged in this scotomas. And how will you pick up this visual field defects? All the visual field defects are easily picked up by perimetry. Remember guys, perimetry. In perimetry, you are having Humphreys perimeter, Amsler's grid also, okay. So anyways, so remember, nasal field is first to be damaged and temporal is last to be damaged. This is regarding what? The visual field defects that you see in glaucoma. Once again guys, just look over here. Learn these visual field defects with me, okay. The visual field defects that you see in glaucoma are what visual field defects? First there is paracentral scotoma, then there is pericentral scotoma, right? Paracentral is there, pericentral is there. Then there is what? Arcuate scotoma, then it takes a shape of a sickle, that is called as Seidel scotoma, double arcuate scotoma, and there is generalized constriction and loss of, generalized constriction of vision or generalized depression of vision. These were what? Visual field defects that you see in glaucoma. So we have discussed about the intraocular pressure of glaucoma, we have discussed the visual field defects. Coming to the third aspect of glaucoma, which is called as what? What optic disc changes will happen in glaucoma, right? First of all, what is optic disc? Optic disc is the beginning of the optic nerve, right? And optic disc changes are usually picked up by direct ophthalmoscopy. They are picked up by direct ophthalmoscopy, right? They are picked up by direct ophthalmoscopy. Now guys, remember, in glaucoma, before going to the optic disc changes, what happens to the arteries and veins of the glaucoma? Remember, there are two central retinal veins and two central retinal arteries. What will happen to the diameter of the artery and vein in glaucoma? The veins will be more dilated. Remember guys, in our body, it is artery that undergoes pulsations, but in our eye, it is the vein that undergoes pulsation. So the vein will be more dilated. The vein will be more dilated as it undergoes pulsations. The only part in the body where the veins undergo pulsation is the eye. But if at all the artery is pulsating, then it is a suggestive feature of glaucoma. Why? Because due to raised intraocular pressure, you might see arterial pulsations in the eye, right? So what will happen guys? Now guys, remember, if you take a cup to disc ratio, first of all we need to understand what I am talking about. Cup to disc ratio. Imagine this is the cup and here is the optic disc, right? This is a cup and here is the optic disc, right? So I was talking about the cup to disc ratio. Cup to disc ratio. First we need to understand this. This is the neuroretinal rim and here is the cup. This is the NRR, neuroretinal rim, and here is the cup. The cup to disc ratio is how much guys? If the normal cup to disc ratio is 0.3 to 0.6. The ratio is 0.3 to 0.6. But if this cup to disc ratio increases by more than 0.7, then it is suggestive of glaucoma. If the cup size increases, then it is suggestive of what guys? Glaucoma, right? So when the cup to disc ratio becomes 1, normally it is 0.3 to 0.6. If it is more than 0.7, it is problematic. But if it is becoming 1, that means the patient has already developed glaucomatous optic atrophy, okay? The cup size here undergoes increasing due to damage of the neuroretinal rim and the optic disc. So basically remember guys, we are discussing about the optic disc changes that are occurring in glaucoma. In optic disc changes, what we need to remember? Retinal arteries and veins. If you see arterial pulsation in the eye, then it is suggestive of glaucoma. Second, the cup to disc ratio is 0.3 to 0.6. If it is more than 0.7, then it is problematic. If it is more than 1, it indicates glaucomatous optic atrophy, right? So what are the signs of glaucoma? What are the signs that you see of glaucoma? We have discussed the visual field defects, we have discussed the disc changes, we have discussed the intraocular pressure changes and all, okay? Now we are discussing the signs of glaucoma. In the signs of glaucoma, you are having a sign called as asymmetry. What is asymmetry guys? Asymmetry, the difference of the cup to disc ratio in a normal person in the eye should be less than 0.2. Just look over here. I am a normal person. When I go for checking my cup to disc ratio, in this eye I will be having 0.4 and in this eye it will be 0.5. What is the difference that I am having? 0.1. Any difference in both the eyes, any difference of less than 0.2, it is fine. But any difference of more than 0.2 indicates that is asymmetry, which indicates the patient is having a chance of developing glaucoma. So remember guys, we are discussing about the signs of glaucoma guys. In signs of glaucoma, the first sign is asymmetry. So guys, remember, in one eye, in my right eye, my cup to disc ratio is 0.3. In my left eye, it is 0.4. What is the difference that I am getting? 0.1 difference. If it is 0.2 difference also, it is fine. But if the difference between the right eye and left eye, if it is more than 0.2, that is the sign of glaucoma. What is that sign? Asymmetry. Asymmetry. If the difference is more than 0.2, that is asymmetry. Apart from that, what else you will see? Right? Imagine guys, this is the neuroretinal rim and here is the cup. So as the patient becomes glaucomatous, what will happen to the cup? There is focal notching of the cup. There is focal notching of the cup, right? Near the neuroretinal rim are the blood vessels, right? Those blood vessels might rupture and next sign could be what? Splinter hemorrhage. Splinter hemorrhage. Due to the splinter hemorrhage, the optic disc becomes pale. The next sign is disc pallor. We are discussing the signs of glaucoma. Signs of glaucoma. First sign being asymmetry. Second sign is focal notching. The third sign is splinter hemorrhage. The fourth sign is what? Optic disc becomes pale. And like disc pallor. As the optic disc is becoming pale, the next sign what that you see is what? All the blood vessels try to come at the nasal side and try to supply the cup. That is called as nasalization of the blood vessels. That is called as what guys? Nasalization of the blood vessels. Once they are supplying the blood to the cup and all, then what will happen? After some time, there will be break in the continuity of the blood vessel, which is called as what? Bionating sign. Which is called as what guys? Bionating sign. So the first sign was what? Focal notching of the cup. Second is what? Splinter hemorrhage. The second is splinter hemorrhage, right? Third is what? Disc becomes pale, disc pallor. Next is what? Nasalization. All blood vessels come to the nasal side. Next is what? Bionating. What is bionating guys? What is bionating? Break in the continuity of the blood vessel is called as bionating. Due to that break in the continuity, a small dot will appear in the cup, which is called as laminar dot sign. Laminar dot sign. So look over here guys, we are still discussing about what? We are discussing about the signs of glaucoma. So as I already told you, the first sign of glaucoma is what? Asymmetry. After asymmetry, there is focal notching. After asymmetry, there is focal notching. After focal notching, what is the next thing? Splinter hemorrhage. After splinter hemorrhage, what is the next thing? The disc becomes pale. Optic disc pallor or disc pallor is seen. Next, what is seen? All blood vessels come to the nasal side, supplying the nasal side. Okay, that is called as nasalization of the blood vessel. Bionating means what? If at all there is the blood vessels which are supplying, if they get broken, that is called as bionating sign. If the blood vessels kink or bend while supplying, then it is called as bionating sign, right? Next is laminar dot sign. A dot appears in the cup, which is called as laminar dot sign. These are the signs of glaucoma. These are the signs of glaucoma. So guys, how will you manage glaucoma? How will you manage glaucoma? First, we need to investigate. Come on guys, what are the investigations done for glaucoma? Glaucoma यानी कि raised intraocular pressure. Raised intraocular pressure के लिए we have to check the intraocular pressure by tonometry and all. Second is what? Visual field defects which are picked up by perimetry. Third is what? Optic disc changes, which are picked up by direct ophthalmoscopy. So these are the three best investigations done for glaucoma. Once you have come to know that this patient is suffering with open angle glaucoma or angle closure glaucoma, next thing is you have to go for the treatment of glaucoma. What should be your aim in the treatment of glaucoma, guys? First of all, why is open angle seen? The basic thing is what? Raise in the intraocular pressure. Why is the raise in the intraocular pressure? Why the intraocular pressure is raised? Why? Because either aqueous humor is being excessively formed or either it is not drained properly. So what should be your aim in open angle glaucoma? What should be your aim in glaucoma, guys? My aim should be either I should increase the outflow of aqueous humor or either I should decrease the production of it. If I can't increase the outflow, decrease the production, in either of ways, intraocular pressure will decrease. So what are the drugs that increases the outflow? I used to remember guys, when you drink Pepsi, a cool drink, when you drink Pepsi too much, your urine outflow will increase. So the drugs that will increase the outflow in glaucoma are, it's not Pepsi, it is Pep B. Pep B. P stands for pilocarpine. E stands for epinephrine. One more P stands for prostaglandin. B stands for brimonidine. Drugs that increases the outflow are pilocarpine, epinephrine, prostaglandin and brimonidine. Drugs which are decreasing the production are, always remember, TB is dangerous. TB is dangerous. T stands for timolol, non-selective beta blocker. B stands for brimonidine. Now you must be wondering, brimonidine is here also and here also. Brimonidine is a drug that acts by two mechanisms. D stands for what, guys? D stands for dorzolamide. D stands for dorzolamide. So remember, guys, drugs that are, remember whenever you are managing, remember first of all, in glaucoma, the first line of therapy is drugs. If drugs fails, imagine a patient is there who is having open angle glaucoma. In open angle glaucoma, your aim should be, I should decrease the IOP. How will you decrease the IOP? Either by increasing the outflow, right? How will you decrease the IOP? Either by increasing the outflow or decreasing the production. Okay? So first line of therapy is drugs. If drugs fails, then what we need to do? You take a laser, and remember what's the pathology of open angle glaucoma? The trabecular meshwork is being fibrosed. So the second modality is what? You take an argon laser and you open the trabecular meshwork. That is called as argon laser trabeculoplasty. ALT, argon laser trabeculoplasty. If ALT also fails, if argon laser trabeculoplasty also fails, the last option for open angle glaucoma is what? Trabeculectomy. But what are we discussing? The drugs. Drugs are very important. What are the drugs, guys? The drugs that increases the outflow and the drugs which are decreasing the production of aqueous humor, right? So guys, we have already discussed over here the drugs which are increasing the outflow and decreasing the production. Now we will discuss each line of drug, starting with the drugs which are increasing the outflow of aqueous humor. Again, starting with anticholinergic drug. Which anticholinergic drug is used? It is pilocarpine. Come on guys, pilocarpine, what does it do? Try to recollect in your mind, you will get the answer. Pilocarpine, what does it do? Pilocarpine increases the outflow. Yes or no? Pep B increases the outflow. So pilocarpine increases the outflow of the aqueous humor. It can be used for open angle as well as what? Angle closure glaucoma. But this pilocarpine comes with some side effects. What side effects? Never use pilocarpine in young patient. Why? Because young patient, when you use pilocarpine, it might land up the patient into pseudomyopia. Apart from that, what else? What are the other side effects of pilocarpine? Pilocarpine can cause, whenever you give pilocarpine to patient, then it can cause uveitis also. You know what is uveitis? Inflammation of the uvea is called as uveitis. Anterior, intermediate and posterior uvea, right? So what we are discussing is pilocarpine is the good drug for managing glaucoma, but it is having some side effects. Now you can take down what are the side effects of pilocarpine. What are the side effects of pilocarpine, guys? Uveitis can occur due to pilocarpine, right? Apart from uveitis, myopia can occur or pseudomyopia, right? Myopia can occur or what, guys? Pseudomyopia. Accommodation spasm can occur, yani ki the ciliary bodies might undergo spasm with pilocarpine. And sometimes there might be a cyst developing on the iris due to pilocarpine use, that is called as iris cyst. Okay? But in these side effects, the most common side effect that you see in young adults if you are using pilocarpine is what? The most common side effect, just right there, guys. If pilocarpine is used in young patients, then it can cause pseudomyopia. That is regarding what? That's regarding pilocarpine. That's regarding what, guys? Pilocarpine. Now coming to the next line of drug, which is called as beta blockers. Come on, guys, beta blockers. Beta blockers. Recollect in your mind regarding the, remember the mnemonic for it is what? The drugs for glaucoma. The drugs that increases the outflow are PEP-B, decreasing the production TBD. So in that, which is a beta blocker that we have discussed? Timolol is a beta blocker. Beta blocker are ending with lol. So timolol. In beta blockers, you are having two beta blockers. One is called as a selective beta blocker, other is non-selective beta blocker. Any beta blocker starting with the alphabet A till alphabet M are selective beta blockers. After alphabet M, they are non-selective beta blockers. So timolol usually comes after M only. So it is a non-selective. Non-selective yani ke it blocks the beta 1 as well as beta 2 receptors. As it is blocking unnecessarily beta 2 receptors also. Timolol, remember timolol is the drug of choice for open angle glaucoma in India, but it is having a side effect. What side effect? You can't give timolol to a patient who is suffering with bronchial asthma. In bronchial asthma, there is bronchoconstriction. Why there is bronchoconstriction? Why? Because already the beta 2 activity is blocked. If you further block it by giving timolol, imagine a patient is having bronchial asthma and glaucoma, never give timolol. It will worsen the asthma, right? So timolol is having some side effects. Right? Even though it is what? A drug of choice for open angle glaucoma, it is having side effects. The selective beta blocker is called as bitoxolol, that could be given in glaucoma. Bitoxolol. Okay. So beta blocker, selective is there and non-selective is there. Selective is bitoxolol, which can be given in asthma and arrhythmias. Non-selective is what, guys? Timolol. It is a drug of choice for open angle glaucoma in India. It can't be given in patient with bronchial asthma and arrhythmias. Why? Why in bronchial asthma? Why? Because in bronchial asthma already the beta 2 activity is blocked, right? And in arrhythmias, if you give timolol, what will happen? Heart block and death can happen. Timolol causes dry eyes in the patient. Timolol causes what, guys? Dry eyes in the patient. Not in all patients. The patient who are suffering with what? Rheumatoid arthritis. The patient who are suffering with rheumatoid arthritis contact lens users. Basically, you can't give timolol in patients who are suffering with rheumatoid arthritis, contact lens users, or who has undergone LASIK surgery. Why? Because already after these things, the patient will be at risk of developing what? Dry eyes. Timolol is having a side effect that it can produce dry eyes, but if it is given to these patients, it will produce dry eyes. Okay. The most common side effect associated with timolol is not all those. The most common side effect is what? It might block the nasolacrimal duct. It can lead to acquired nasolacrimal duct obstruction. The most common side effect of timolol use is what, guys? Acquired nasolacrimal duct obstruction. Next is what? Epinephrine. Epinephrine or adrenaline. Come on, guys. Now, guys, remember the drugs that are increasing the outflow were PEP B. The drugs that were decreasing the production were TB is dangerous. Always remember TBE dangerous. Yani ki T is timolol, B is brimonidine, E is epinephrine, and D is dorzolamide. Now guys, epinephrine. Epinephrine is a drug. Remember, epinephrine and brimonidine are the drugs which are acting by two mechanisms. Epinephrine or adrenaline is a drug that acts by two mechanisms. What two mechanisms? It decreases the production as well as increases the outflow. But this epinephrine is also coming with many side effects. What side effects? Come on guys, we are talking about epinephrine. If you give epinephrine drops, it might get absorbed systemically, leading to what? Hypertension, tachycardia, palpitations, nervousness, anxiety and all, right? So, tachycardia, hypertension, sweating, nervousness, palpitations can be seen with what? Adrenaline. So, nowadays, what we are using, guys, instead of adrenaline, we are using a prodrug of adrenaline which is called as dipivarfine. A prodrug of epinephrine which is called as dipivarfine, which is free from systemic side effects. But this dipivarfine is having a side effect that it can cause blepharoconjunctivitis. Blepharo is eyelids, conjunctivitis is inflammation of the conjunctiva. So, it can cause inflammation of the eyelids as well as conjunctiva, leading to blepharoconjunctivitis, right? So, remember, dipivarfine does not have any systemic side effects. It's similar ocular side effects, but no systemic side effects. Okay. So, remember, we are talking about what? We are talking about this drug called as adrenaline, right? Right, guys. So, remember, whether it is adrenaline or dipivarfine, the ocular side effects are what? They may dilate the pupil and sometimes they might lead to angle closure glaucoma. But remember, the most common side effect which is associated with dipivarfine is what? Blepharoconjunctivitis. Once again, guys, the drugs which are increasing the outflow are PEP B, pilocarpine, epinephrine, P say prostaglandin, D say dorzolamide. B say, once again, the drugs which are increasing the outflow are PEP B, pilocarpine, epinephrine, prostaglandin, brimonidine. Drugs which are decreasing the production are TB is dangerous. T stands for timolol, B is brimonidine, E is epinephrine and D is dorzolamide. Okay. Now, next is carbonic anhydrase inhibitors. What carbonic anhydrase inhibitor drug which are we using in glaucoma? There are two carbonic anhydrase inhibitors. One is the systemically used, other is the topically used. The systemically used drug is what, guys? It is basically what? Acetazolamide, right? Topically uses topically uses what? Dorzolamide. Now the systemically used drug is acetazolamide. But is acetazolamide a pleasant drug? No, sir. It is having many side effects. It is contraindicated in a patient who is having sulfur allergies. If you give acetazolamide to a sulfur allergy patient, he will land up into what? Stevens-Johnson syndrome. Never give acetazolamide for a patient who is having what? Any renal stone or renal failure. Why? Because it will worsen the renal failure. So overall, acetazolamide is a worse drug. So instead of acetazolamide, what are we using for glaucoma? Dorzolamide. You have to tell what is the mechanism of dorzolamide and glaucoma. whether it is increasing the production or whether it is decreasing the production or increasing the outflow. It increases the outflow. It increases the outflow. But this dorzolamide also comes with a complication. What complication? When you give dorzolamide drops to the patient, what will happen? Whenever dorzolamide is used for a longer period of time, it will cause damage to the cornea, which leads to corneal decompensation. So we are talking about what? Carbonic anhydrase inhibitors. What is the function of carbonic anhydrase inhibitors? They decrease the production of what? They decrease the production of aqueous humor, right? So there is systemically used acetazolamide and topically used dorzolamide. But I told you acetazolamide is contraindicated in some patients. Acetazolamide is contraindicated in the patients who suffer from sulfa allergies. If you give acetazolamide in sulfa allergy patient, it can land up the patient into SJS. What is SJS? Steven Johnson syndrome. SJS is Steven Johnson syndrome. Apart from that, acetazolamide is also contraindicated in renal failure. Acetazolamide is contraindicated in renal failure. So remember, overall acetazolamide is a highly unpleasant drug. Overall, it's an unpleasant drug. So instead of acetazolamide, what are we using? We are using what, guys? We are using dorzolamide. We are using what? Dorzolamide. But I told you, dorzolamide is a very good drug, but it comes with a complication. What complication, guys? It comes with a complication of corneal decompensation. You can remember, guys, dorzolamide is a drug of choice for, right there, guys, dorzolamide is a drug of choice for open angle glaucoma in children. But the most common side effect of it is very, very important. The most common side effect associated with dorzolamide use is what? Corneal decompensation. The most common side effect associated with dorzolamide use is what, guys? Corneal decompensation. Coming to the next drug, which is called as what? Alpha agonist. What alpha agonist? Alpha 2 agonist. What two alpha agonists are used? So, dorzolamide is a drug of choice for open angle glaucoma in children with a side effect of corneal decompensation. Now, coming to the next line of drug, which is called as alpha 2 agonist. In alpha 2 agonist, we are having what? We are having two drugs, brimonidine and apraclonidine. Come on, guys, mechanism of action of brimonidine. What comes to your mind? The mnemonic should come to your mind. Drug increases the outflow, pep B, decreases the production, TBD. Brimonidine कहाँ पे आ रहा है वो? Brimonidine comes in the pep B also and TBD also it is coming. यानी कि brimonidine is a drug that acts by two mechanisms, increases the outflow as well as decreasing the production, right? So now, guys, remember brimonidine has the unique property of neuroprotection. Brimonidine has unique property of neuroprotection. Brimonidine has a unique property of neuroprotection. Apart from that, what else we need to remember regarding brimonidine? Brimonidine has a unique property of neuroprotection. Apart from that, what else we need to remember? Brimonidine acts by two mechanisms. It acts by two mechanisms. What two mechanism? It increases the outflow as well as decreasing the production. But never give this brimonidine in children. Why? Because it will cause drowsiness. It will cause drowsiness, right? So apraclonidine. Regarding apraclonidine, we haven't discussed. Apraclonidine is the drug that could be used for post-NDAG capsulotomy. Yani after NDAG, you know what is NDAG laser used for? NDAG laser is used for the management of after cataract. So when you use NDAG laser, sometimes the intraocular pressure increases much. There you can use what? Apraclonidine. It is commonly used for post-YAG capsulotomy to control the intraocular pressure. The side effect associated with it is what? Tachyphylaxis could be seen. Okay. So anyways guys, brimonidine we have to remember for glaucoma. Apraclonidine is not used for glaucoma. It is used for decreasing the pressure of after NDAG capsulotomy. Next line of drug is what? Prostaglandin. Very costly drug called as latanoprost. Come on guys, prostaglandin. What prostaglandin are we talking about? First of all, what is the mechanism of action, guys? When I am asking mechanism of action, you should basically go towards what? The mnemonic. The drugs which were increasing the outflow are PEP-B. Pilocarpine we have discussed. Epinephrine we have discussed. Third P stands for prostaglandin. So prostaglandins are the drugs that increases the outflow. Are they increasing the outflow by the normal pathway? No. Aqueous humor normally flows by the normal pathway. What is the normal pathway of aqueous humor? After being formed from the ciliary body, it goes from the pars plicata into the posterior chamber, goes into the pupil, from the pupil into the anterior chamber, from there it goes to the angle, from there it goes to the trabecular meshwork, Schlemm's canal and episcleral veins. That is the normal pathway. But 10% of aqueous flows through the uveoscleral pathway, and this prostaglandin increases the outflow of the aqueous humor by what pathway? Uveoscleral pathway. It is a very costly drug. It is a drug of choice for open angle glaucoma in United States, but it also comes with some side effects. Okay, we'll discuss the side effect later. First, what are we discussing? Prostaglandin. Prostaglandin, what is the example that we need to remember? Latanoprost. It increases the outflow by what pathway? Uveoscleral pathway. In normal eye, the aqueous humor flows by 90% of aqueous humor flows by what? Trabecular meshwork. 10% by uveoscleral pathway. It is a drug of choice for low tension glaucoma. It is the most powerful and the potent anti-glaucomatous drug, and in US it is a drug of choice for open angle glaucoma. But the side effect associated with this drug is what? Same like pilocarpine. This will also cause what? Uveitis. This will also cause what? This will also cause what? Blepharoconjunctivitis. Pilocarpine was also causing the same side effect. Yes or no? Uveitis and blepharoconjunctivitis. Apart from that, it might also cause cystoid macular edema and iris hyperchromia. Cystoid macular edema is what, guys? What is cystoid macular edema? Edema of the macula occurring in a cyst-like fashion is called as cystoid macular edema. What is hyperchromia? Iris hyperchromia. Whenever you give latanoprost to the patient, the iris color, whichever the color is, it becomes hyperpigmented and all. So anyways guys, remember, we are discussing about latanoprost. Side effects of latanoprost and pilocarpine are almost similar. Uveitis, blepharoconjunctivitis. Apart from that, what else you can see? Sometimes cystoid macular edema or iris hyperchromia could be seen after using what drug? Latanoprost. Right? Coming to the last line of drug, which is called as what? Glycerol or mannitol. Come on guys. Did I teach you about glycerol or mannitol while discussing the mnemonic? No. Why? Because glycerol or mannitol, it is the drug that is commonly used in angle closure glaucoma where the intraocular pressure is very, very high. In open angle glaucoma, the intraocular pressure is not that much high, but angle closure glaucoma, the intraocular pressure is very, very high. So what we do is, when a patient of angle closure glaucoma comes, first we need to decrease the intraocular pressure. Remember, mannitol is also used for decreasing intracranial pressure, right? So remember, the hyperosmotic agents such as glycerol and mannitol, they are used in angle closure glaucoma, right? They are two drugs which are given IV in glaucoma. There are only two drugs which are given intravenous in glaucoma. That one is acetazolamide, which is not used nowadays. Second is mannitol. Why do you give mannitol? Mannitol is given to reduce the intraocular as well as intracranial pressure. So guys, remember, mannitol is a, right there, mannitol is a drug of choice. Mannitol is a drug of choice for angle closure glaucoma. Mannitol is a drug of choice for what glaucoma, guys? Angle closure glaucoma. It is the fastest acting. It is the fastest acting anti-glaucomatous drug. It is the fastest acting anti-glaucomatous drug which is used in the management of glaucoma, but it is contraindicated in the patients who are suffering with congestive heart failure. Contraindicated in congestive heart failure. Is there any role of atropine in glaucoma? No, no role. Atropine is only given for malignant glaucoma. Atropine is only given for malignant glaucoma. Atropine has no role in the management of glaucoma. It is best used for malignant glaucoma. What is meant by malignant glaucoma? Don't tell me that due to malignancy patient developing glaucoma. No. After any surgery, patient develops glaucoma is called as malignant glaucoma. Malignant glaucoma means what? Glaucoma developing after a long standing ocular surgery. Long duration ocular surgery. After that, the intraocular pressure raises. That is called as malignant glaucoma. The treatment for malignant glaucoma is atropine. Otherwise, there is no role of atropine in glaucoma. So, remember guys, I told you, in open angle glaucoma, the first line of therapy is drugs. The drugs will have two aims. Either they increase the outflow or decrease the production. That is the aim of the drugs. Okay. If the drug fails in open angle glaucoma, if the drug management fails in open angle glaucoma, remember, the pathology of open angle glaucoma is trabecular meshwork fibrosis. If the drug fails, take an argon laser and open the trabecular meshwork, which is called as argon laser trabeculotomy. It is called as what, guys? Argon laser trabeculotomy, or it is also called as argon laser trabeculoplasty. If that also fails, the last option over here is what? Remove the pathological thing. What is the pathological thing over here? Trabecular meshwork. The last option is trabeculectomy. So remember guys, in open angle glaucoma, it is done, the treatment is done in 3 stages, right? The first thing is you give the drugs. If drug doesn't work, then you have to go for argon laser trabeculoplasty. If that also doesn't work, then you have to go for trabeculectomy. That also fails, then you have to go for what, guys? Trabeculectomy. That is the management for what glaucoma? Open angle glaucoma. Open angle glaucoma. Now coming to what? Angle closure glaucoma. How will you manage angle closure glaucoma? First, keep this thing into your mind. Any angle closure glaucoma, his intraocular pressure will be sky high. He will be having an intraocular pressure of 60 mm of Hg. Even though, remember, the best management for angle closure glaucoma is the surgical only. But before going towards surgery, first decrease the pressure. So, what is the drug that is used to decrease the pressure? When a patient comes with angle closure glaucoma, I will give the patient mannitol. His intraocular pressure decreases. Then what will I do as his intraocular pressure decreases? What should I do, guys? What should I do? Then I have to go for the surgery. Now you will be asking, sir, what surgery will you go for angle closure glaucoma? You need to understand, guys. In angle closure glaucoma, what is the problem? I'll give you a scenario. I'll give you a scenario with the help of pictures so that you can understand, okay? Come on guys, this is the cornea. This is the ciliary body, ciliary zonule, lens, iris. In angle closure glaucoma, iris is sticking to the lens like this. Now what is happening, guys? Here is the structure called as angle. Here is trabecular meshwork, here is Schlemm's canal, last is the episcleral veins. So as remember, The basic pathology of angle closure glaucoma is mid-dilated pupil that leads to posterior synechiae. As there is posterior synechiae, what happens? Iris bombi. Iris gets bulged. Due to the bulging of the iris, angle is closed. So in angle closure glaucoma, what should be my aim? The iris that are stick to the lens, I should remove that iris. I should remove the iris from the lens. So what should I give? I will go for iridotomy. To remove the iris from the lens, I will go for a help of laser. With the help of laser, I should remove the iris from the lens, which is called as what? Iridotomy. So what will I do, guys? What will I do? I take a laser and with the help of the laser, I remove the iris. That is called as laser iridotomy. Laser iridotomy. Laser iridotomy, right? But if at all that doesn't work, then you have to go for iridectomy also. Dectomy yani ki removal of the iris. Okay. So what we do over here is laser iridotomy. Laser iridotomy is the best management for management of angle closure glaucoma. What is the laser that we use in this iridotomy? Again, it is the same laser that was used for after cataract. What is that laser? Nd:YAG laser. Nd:YAG laser, right? So the laser that we use over here is what, guys? Nd:YAG laser. But what should be kept into your mind? First, as the patient is coming, what we need to do? First, we give mannitol to reduce the intraocular pressure. It will take 3 to 4 times. It will take 3 to 4 days. We'll repeat from here. First, we will give mannitol to the patient who is coming with angle closure glaucoma. That will reduce the intraocular pressure and it will take 3 to 4 days to reduce the pressure. Once the corneal edema is settled, then we have to go for laser iridotomy. Laser iridotomy. Okay? Laser iridotomy. Sometimes, remember, most of the times, the patient who is developing angle closure glaucoma in one eye, the other eye will also be at risk of developing that angle closure glaucoma. So, in the other eye, we can go for prophylactic iridotomy. Prophylactic iridotomy. Okay. So, the treatment of choice for angle closure glaucoma, the medical management is what, guys? Mannitol, and the definitive management is laser iridotomy. Right there, laser iridotomy. The prophylactic management, the main medical management is mannitol, and whereas the main management is laser iridotomy. This is regarding what? This is regarding the angle closure glaucoma management. Open angle glaucoma, the best management is giving the drugs. First, we give the drugs. If the drugs fails, we go for argon laser trabeculoplasty. If that also fails, trabeculectomy. Now, guys, remember drugs I told you in open angle glaucoma, there are two aims of the drug. Either increasing the outflow, just tell me the mnemonic, PEP-B, pilocarpine, epinephrine, prostaglandin, brimonidine. Drugs which are decreasing the production are TB is dangerous. Timolol, brimonidine, epinephrine and dorzolamide. Okay. If that fails, the argon laser. If argon laser fails, then you have to go for what? Last option is what, guys? Trabeculectomy. Whereas in angle closure glaucoma, the best management is laser iridotomy. But what we need to do is, before going for laser iridotomy, we first give mannitol to the patient that reduces the intraocular pressure. Okay. That's regarding what? That's regarding the management of angle closure glaucoma. Now coming to the next thing, which is called as secondary glaucoma. What is meant by the term secondary glaucoma? Secondary glaucoma meaning what? Glaucoma developing secondary due to some disorders. That is called as secondary glaucoma. The examples of the disorders that can lead to glaucoma is called, in secondary glaucoma you are having pigmentary glaucoma. Pigmentary glaucoma. Pigmentary glaucoma is a type of glaucoma where there is deposition of the pigment. Remember guys, what happens in pigmentary glaucoma is, in some patients there might be some, remember which is the highly pigmented or highly colored area of the eye? It is the iris. Highly pigmented, deeply pigmented. What happens in some conditions is, the iris starts to melt off and it loses the pigment. That pigment, what will happen? It goes into the trabecular meshwork, blocks the trabecular meshwork. And once the trabecular meshwork is blocked, the What happens to the aqueous humor? Aqueous humor cannot flow out. That leads to raising the intraocular pressure and hence lead to glaucoma. Sometimes the pigment goes and most of the pigment goes into trabecular meshwork and block it, leading to pigmentary or secondary glaucoma. Sometimes that pigment also goes at the back of the cornea, forms some spindles beneath the cornea, which is called as Krukenberg spindle. Very, very important. Krukenberg spindle. So, pigmentary is a type of glaucoma where there is deposition of the pigment which can block the trabecular meshwork, and some of the pigment gets deposited in the cornea in the shape of a spindle in the corneal endothelium, which is called as what? Krukenberg spindle. Which is called as what, guys? Krukenberg. This secondary or pigmentary glaucoma, it is seen in again males and myopes. If a patient is coming with pigmentary glaucoma, just give them pilocarpine. It will open the trabecular meshwork to a very much extent so that the pigment also goes off from there. Okay? The drug of choice for pigmentary glaucoma is pilocarpine. Remember guys, pigmentary glaucoma risk is high in young males and myopes. Just now I told you before only that in young patient, if you give pilocarpine, what will happen? Pseudomyopia. But we can take a risk over here. It is the only place where the young patients are given what? Pilocarpine. Okay? So, pigmentary glaucoma, the drug of choice is what, guys? Pilocarpine. Next. So, we are discussing about secondary glaucoma. Secondary glaucoma meaning glaucoma developing due to some underlying disorder. Such as what, guys? One is pigmentary. Second is what? Neovascular glaucoma. Neovascular glaucoma. Neovascular glaucoma. Second is what, guys? Neovascular. Neovascular glaucoma meaning what? New blood vessels developing on the iris. When will new blood vessels develop on the iris? Whenever there is hypoxia-like condition in the eye senses that there is hypoxia. Okay? The blood flow is decreased, oxygen supply is decreased. So what will happen? There is this enzyme released in the eye which is called as VEGF. In our body only there is, remember, whenever the blood supply or there is hypoxic-like condition in the body, the blood vessels releases a thing called as VEGF, vessel endothelial growth factor. This VEGF leads to formation of new blood vessels. In the eye, whenever there is hypoxia-like condition which might be created due to CRAO, CRVO, BRAO, BRVO. CRAO is central retinal artery occlusion. CRVO is central retinal venous occlusion. So anyways, whenever this condition is being created in the iris senses that there is what? Hypoxia. This iris will produce VEGF. There will be new blood vessels formed on the iris which is called as rubeosis iritis. And this new blood vessels, as they are formed on the iris becomes heavy and it sticks to the lens. And next story you guys remember, if iris sticks to the lens, what will happen? Posterior chamber is closed, pressure increases, iris bombi leading to what? Angle closure glaucoma. So remember guys, neovascular and such a glaucoma that is occurring due to new blood vessels developing is called as neovascular glaucoma. It is a most dreadful glaucoma with the worst prognosis which can be seen due to neovascularization of the iris which is called as rubeosis iritis. Which is called as what, guys? Rubeosis iritis. What is the cause of neovascularization? Right guys, what is the cause of neovascularization? Okay? The cause of neovascularization is what? The causes of new blood vessels developing on the iris. CRAO, CRVO, right? Sickle cell anemia, Eales disease. Sickle cell anemia and Eales disease, which is also called as periphlebitis retinae, which is seen after the tubercular infection. We will discuss that later. So, these are the causes of what? Due to these diseases, new blood vessels develop on the iris, pushes the iris towards the lens leading to angle closure glaucoma, right? So, neovascular glaucoma, how will you treat this neovascular glaucoma? Whenever you hear the term neovascularization, the immediate answer that should come to your mind as a treatment is what? Photocoagulation. Sir, whenever new blood vessels are formed in the eye, I will take a laser, I will photocoagulate all the new blood vessels so that there is no sticking of the iris to the lens and all. Okay. So the early presentation, first of all, if the patient is presenting in the early stages, first try to treat the hypoxia. Okay. Then you have to go for photocoagulation, pan-retinal photocoagulation. If the patient is presenting very late, and after developing neovascularization, he comes to you. Before developing neovascularization, you just treat hypoxia. But if new blood vessels are already being formed in the later stages, then you have to go for a cyclodestructive therapy, which is called as diode laser photocoagulation. Diode laser cyclophotocoagulation, right? DLCP, which is called as DLCP. DLCP is what, guys? Diode laser cyclophotocoagulation, right? So if the patient is presenting early to you, how will you manage? You just treat the hypoxia. That is, if you treat the hypoxia, no new blood vessels are formed. But if the patient presents late to the hospital, is coming with new blood vessels, destroy the blood vessels with DLCP. What is DLCP? Diode laser cyclophotocoagulation. Diode laser cyclophotocoagulation, right? The last secondary, remember guys, in secondary glaucoma, there is pigmentary glaucoma, there is neovascular glaucoma, and there is lens-induced glaucoma. Lens-induced we have already discussed, guys. Phacomorphic glaucoma, phacolytic glaucoma, there is also phacoanaphylactic glaucoma. Phacomorphic meaning what? In the stages of cataract, if you guys remember, I told you there is early incipient stage, there is immature stage, there is mature stage, and there is hypermature stage. In the mature stage, the lens bulges, called as intumescent, that sticks to the iris, leading to closure of the posterior chamber, leading to angle closure glaucoma. That is phacomorphic. Whereas in the hypermature stage of the cataract, the lens loses all the water as well as the crystalline proteins, which goes and stucks into the trabecular meshwork, leading to open angle glaucoma. Remember, right? So phacomorphic glaucoma, it is seen in due to the intumescent. It is not indue, it is INT. Intumescent lens of the mature cataract pushes the iris towards the cornea or pushes the iris towards the lens. Iris towards the lens and may block the angle. The intumescent, we'll repeat from here. The intumescent lens of the mature cataract pushes the iris towards the lens, and once the pressure, once it is closed, once the posterior chamber is closed, then the iris is slowly pushed towards the cornea, leading to what? Angle closure glaucoma. Phacolytic meaning what? I told you, in hypermature stage of the cataract, there is micro leaks of the capsule of the lens, which blocks the trabecular meshwork, right? Phacoanaphylactic meaning what, guys? After, remember, if a patient of cataract surgery comes, you go for operation called as ECCE plus PCIOL. And okay, you give an incision on the capsule, you remove the lens, and then you insert a intraocular lens. Some of the patients are allergic to the new intraocular lens that you have introduced. If a patient develops anaphylactic reaction against the lens after cataract surgery, and that might land up the patient into what, guys? That anaphylactic reaction might increase the intraocular pressure, might damage the optic nerve and lead to visual field defects, that leads to glaucoma. Phacoanaphylactic meaning what? Due to allergic reaction of the right. Repeat it once again. Phacoanaphylactic meaning what? We'll repeat from here. Phacoanaphylactic meaning what? Due to the anaphylactic reaction of the lens that has been put in the patient's eye. Due to that anaphylactic reaction, the patient's intraocular pressure is increased and the patient develops glaucoma. That is called as phacoanaphylactic glaucoma, right? So lens induced, there is phacomorphic, phacolytic. Phacomorphic seen in which stage of the cataract? Mature stage. Phacolytic, hypermature stage. Last is phacoanaphylactic. Okay guys, thank you. This was the topic of glaucoma.